Hello, I'm Dr. Pat Hennessy. Today I'll serve as your tour guide as we look at a slideshow developed by Physicians for a National Health Program, of which I'm the Montana coordinator. My goal in today's program is to explore and explain the problems of our current healthcare system. I've practiced in Western Montana since 1977, and while I've been trained as a family physician, I also have additional specialty training in public health and health policy. For the fourth time in this century, Americans are attempting to improve their healthcare system. The first time we attempted to do so, Jeannette Rankin led the way right after World War I. Major forces lined up to block that attempt. Two additional times, our national legislators were sidetracked from reform efforts by our entrance into World War II and the Vietnam conflict. In 1994, we are closer to real reform than we have been in over 30 years. Once again, major forces are lining up to block the will of the people. Today we hope to explore the concepts of cost, access, quality, administration, and financing. There's some who will patronizingly tell you that as a layperson you can't possibly make sense of these complex issues. As you'll soon see from the slides that follow, this just isn't so. The average Montana citizen can clearly see the issues when they're accurately presented. We'll start with slides that illustrate the problem on a national level, and then we'll conclude with some Montana-specific slides. The first slide that we'll look at is a generic cost increase slide. As you can see, there's an exponential increase in costs, and our current spending mirrors this. In 1991, we paid $602 billion for health care costs, $738 billion in 92, $935 billion in 93, and this year it's estimated we will spend $1 trillion on health care in this country. That's a 1 followed by 12 zeros. It's over 14% of our gross domestic product. Now, when we look at this next slide, you can see that while costs for health care are going up for Americans, Americans' real wages are not doing so well. When we look at this slide, which shows change in real wages in the index years 1980 through 1990, the source for this slide is the International Monetary Fund. When we look at other countries, members of the Common Market, United Kingdom, Germany, France, Japan, Sweden, Italy, and Canada, you can see that real wages actually increased in most of those countries. In Canada, the increase was much slower, and in the United States, real wages actually decreased. When people say, oh well, the 80s was a time of boom, how could it be that Americans did not appreciate real increase in wages? When you look at this slide, whose source is Citizens for Tax Justice, you can see that when we look at the income groups where there was in fact real increase in wages, you can see that the top 1% did exceedingly well, followed by the top 4%. The rest of us made modest increases, and the lower 60% of Americans actually noted real decrease in their income. While incomes are decreasing, healthcare costs are increasing. You can see from this slide, which comes from the Oxford Review of Economic Policy, that in the United States we have a peculiar funding mechanism. It's called a regressive health financing system, in which the poor pay more as a percent of their total income than the rich do. This slide is quite famous now. In fact, there's lots of argument. Is it 35 million uninsured? Is it 29 million? Is it 39 million uninsured? What we know is that who in fact does not have access to health care is flexible over time, especially here in Montana where people are part-time and oftentimes seasonal workers. Many people also will tell you that these uninsured people are non-productive members of society. When we look at the next slide, and this is information that's taken from the Census Bureau, from the current population survey, you can see that most of the people who are uninsured are employed. The next largest group are children. There are some who are, in fact, unemployed and uninsured, 7%. But there's a large category of people called the out-of-labor force, which includes disabled individuals, early retirees, students, and homemakers. In addition to the problem of uninsurance is the problem of underinsurance. This slide illustrates a concept of the fact that many people, if in fact they were to have a catastrophic illness, would be bankrupted by their illness in attempting to pay for it. And this information comes from the Senate Select Committee on Aging. We know that Medicare recipients pay greater than 50% of their medical bills out of pocket. They pay 18% of their income for out-of-pocket costs and pay less than 50% of their total costs. In our country, health care is largely linked to employment and the generosity of employers. This slide illustrates a concept called job lock. Because we know how the great lengths that individuals will undergo to maintain their benefits and maintain a sense of a good employee benefit package, there are some who believe that, in fact, people will not stray from a job if, in fact, it has a good benefit coverage. This slide illustrates information that comes from the New York Times and a CBS poll, and individuals were questioned. Has anyone in your household ever stayed in an unwanted job for the sake of health coverage? Adults who said yes by family income. When we look at the lowest paid jobs and the highest paid jobs, you can see that only about 1/5 of individuals said yes. But when we look at jobs, in the category 15 to 20% and $30,000 to $50,000, you can see that a significant number of these individuals are staying in an unwanted job to maintain their health coverage. The next issue that we'd like to deal with is a complex one, and that has to do with quality. Whenever we talk about the problem of costs and access, many individuals say, well, we have the best care in the world. It doesn't matter if we spend 14% of our gross national product. We have the highest standard of excellence of all developed countries. I'm going to look at a series of slides that deal with the quality issue. And this particular issue is somewhat difficult to understand because we're looking at doctors rating different procedures based on how effective and efficient they are. In essence, are we getting good bang for our buck? The first slide is information that was published in the Journal of the American Medical Association. And the researchers who compiled the data were the RAND Corporation, which is a major health policy think tank. And what they chose to show is that 2 very costly vascular procedures performed in the United States have a degree of appropriateness that may be surprising. When we look at the first pie for something called coronary artery bypass grafting, you can see that it was felt to be appropriate over half the time. It was felt to be of equivocal quality, roughly 20% of the time, and inappropriate 18% of the time. When we look at another procedure called endarterectomy, which is oftentimes performed on the blood vessel in the neck, you can see that roughly it was felt to be appropriate 1/3 of the time, equivocally appropriate 1/3 of the time, and inappropriate 1/3 of the time. It's important to understand that these procedures are extremely costly and part of the burgeoning inflation in healthcare costs. The next slide illustrates similar information, and that is information that comes to us from Colorado and the Colorado Health Data Commission. And that is that when we look at standards posed by the American College of Surgeons to maintain competence, only 3 of 8 Denver hospitals qualified in terms of performing the appropriate number of surgeries necessary to maintain quality. This is another example of a quality problem. And it has to do with the fact that the more machines you have, the worse care you may have and the higher costs you may have. This is information that was published in the Annals of Internal Medicine, and it suggests to us that we currently have 10,000 mammography machines in the United States when 2,000 could meet all the current demand. Because machines are underutilized, cost per test is higher than necessary and quality suffers. Now, many people would argue, so what if we're paying too much? So what if we have too many machines? So what if we're spending too much on surgeries that may or may not be appropriate? Let's look at the outcome measures. After all, we do have the best system in the world and we have the best outcomes, correct? This slide suggests otherwise. This is information that looks at life expectancy for women in the year 1989, and it's information that was provided to us once again by the Office of Economic Cooperation and Development. And you can see that the United Kingdom and the United States have a much lower life expectancy for women than other countries within the common market. Perhaps children do better. In this slide, which illustrates infant mortality provided to us by the same source, you can see that the people with the lowest rate of infant mortality are Japan and Canada. The United States is higher than any of the peers mentioned here. The people with the nearest closest poor outcomes are Italy and Australia. Men fare about the same. Once again, you can see that the United States lags behind its neighbors regarding total life expectancy for men. Now, these outcome measures are hard to interpret at times because they don't suggest that they may, in fact, hide the fact that there are some strata in the United States where we're actually doing better in terms of life expectancy and in terms of infant mortality. But you can see that there are other places, since these are average figures in the United States, that are doing much worse. So these are average figures averaged against other countries. This next slide illustrates a concept that always comes up, and that is, well, how does malpractice fit into all of this system? Now, the concepts that are illustrated in this slide are a little confusing, and I'll try to walk you through them, although the illustration may be a little bit hard to follow. This is information that's taken from the Harvard Malpractice Project, and it was published in the New England Journal of Medicine. And it was information taken from New York State and extrapolated to the United States as a whole. And it describes negligent injuries to hospital patients. Now, malpractice indicates that there has been a bad outcome and there has been a wrongful act by an institution or a healthcare provider. And so malpractice, in order for someone to be guilty of malpractice or have committed malpractice, there has to be both the damage component and the wrongful act component. All of us understand that there are some bad outcomes for which there's no one to blame. And all of us understand that at times there are wrongful acts, but there's no faulty outcome or no bad outcome. And so this slide will illustrate information that suggests there's, in fact, a 1% malpractice rate in the United States in injuries to hospitalized patients. As we follow through the slide, it's estimated that we had close to 33 million hospital admissions. And when we look at the slide, you can see that roughly there were 1% or 33,000 acts of malpractice. Amongst those, there were, in fact, some poor outcomes resulting in death. But there were very few malpractice suits in this group where there, in fact, was malpractice. Very few suits. When you look at where the bulk of the suits are, 85% of the suits were in an area where there was no malpractice. Now, what this explains, or it attempts to illustrate, is that we believe that when even though there has been no negligence, when in fact there's a poor outcome, a bad outcome that makes an individual medically uninsurable, that individual will attempt to secure future medical benefits and health care costs through attempts of a suit. And so we believe that some of these episodes of suit in an area where in fact there is no malpractice have to do with people who know they are now medically uninsurable. Our next slide illustrates an example of the administration and financing of our current payment system. Our current payment system is called an unregulated multi-payer. And if you look, you can see that in our current system, we have healthcare providers, healthcare institutions, drugs and medical goods, all financed by third-party administrators such as insurance companies, VA, CHAMPUS, IHS, Medicaid. 1,500 different companies basically pay all of the providers, goods, and institutions in this country. And into those 1,500 different third-party administrators include contributions that come from individuals, come from state and local government, come from employers, and come from the federal government. The Clinton proposal would maintain the current system's inefficiencies while expanding access. This is an unregulated multi-payer system. When you look at this slide, some concepts will be really well illustrated. It's almost impossible to regulate a multi-payer system. Embedded in these 1,500 different entities which are paying the bills are an army of people designed to administer and modify the system. It is the most heavily bureaucratized healthcare system in the world. Every insurance company has sales officers, actuaries, benefit clerks, eligibility technicians, payment reviewers, and in every hospital and doctor's offices there are specially trained staff dealing with each of these payers, responding to their own special rules with special forms, etc. This is a tremendously inefficient system. It's estimated, Congressional Budget Office estimates last year estimate that we spent $90 billion administering the system. This year it's estimated we'll spend $100 billion administering the system. This slide just is an example of the concept we just talked about. It illustrates the growth in administration. It comes from the Statistical Abstract of the United States, and it shows that while we have a steady increase in the number of physicians, we have an additional exponential curve in administrators. Roughly, we train 6 administrators for every physician. Now, one of the other interesting factors that we're seeing pertaining to administration issues in the United States has to do with the concept illustrated in this slide, which is the percent change in hospital employment in the index years by occupation, 1983 to 1989. During this time period, you can see that there was a modest increase in the number of people employed by hospitals, and this comes from the Monthly Labor Review. If you look at the fastest growing sector, you can see that it's in administration and in marketing of hospitals. Professional staff and nurses made modest increments, but nurses' aides suffered a significant decrease, 27% decrease at the same time. Anyone who's worked in a hospital knows that nurses' aides are the people that have the most direct patient contact. This is an illustration of the paperwork costs, the administrative costs that our system has, which our nearby neighbor, Canada, does not have. If you look at this slide, you can see that, and this is information that comes from the New England Journal of Medicine, you can see that in our country we pay roughly 76 cents out of every dollar for health care costs and 24 cents out of every dollar for health administration. Canada has less than half that amount, roughly 11%. Now, Canada has a system very similar to ours, and we've already seen that it has better outcomes. The area in which they are different is that they have a single-payer system of health care, a single-payer financing system. Now, when people ask about what is single-payer, there's a tremendous amount of propaganda and misinformation that is applicable to that. Single-payer isn't a system where all the doctors are fired and all the hospitals are closed and then they reopen, kind of like the Pentagon. Single-payer is a healthcare system that is financed with single-payer mechanism. The single-payer doesn't say anything about how the doctors operate or what kind of drugs you can purchase. It is best illustrated by the following slide, which shows that instead of having multiple 1,500 different third-party administrators paying doctors, institutions, and drugs, all monies travel into a state National Health Plan fund, all contributions from individuals, employers, state and local, and based on guidelines determined by the citizens of that state, monies are dispersed to hospitals, providers, and for drugs and medical goods. Now, when we talk about a national health plan, that there are some principles that we think should occur under the single-payer system, and that is that we think everyone should be covered for all medically appropriate diseases or for all medically appropriate problems, and that it should be financed by a single publicly administered entity. This slide illustrates different options for physicians. Oftentimes, people have the anxiety that health care reform will mean that people can't choose their doctors anymore. Under a national health plan that is being put forth by Physicians for a National Health Program, endorsing a single-payer concept of financing, you can see that there are three options for physicians, very much like the current options we have. There's a fee-for-service option, which is basically the way many physicians in Montana bill their patients. There's a capitated system for institutions. For example, I have worked at the University of Montana Student Health Service, and that's an institution in which students are assessed a fee at the beginning of the year, and that's how we make the system run. Globally budgeted institutions are the last area in which doctors may practice, and that has to, for example, hospital-based physicians like emergency room physicians can be paid under that option. That pretty much describes all the ways physicians currently operate in the United States. So under a single-payer national health plan, there would be no change in how doctors operated, nor would there be a change in which doctors you were free to choose to see. Hospital payments would change somewhat. Hospitals would remain privately owned, but they would have two different budget plans. They would have an operating budget which had to do with their day-to-day expenses, but there would be a separate capital purchases budget. And the amount of money allocated to the hospital would be based on health planning goals for the state as a whole, not just what that particular hospital chose to do. This is another way of looking at that, and that is that capital funds would be distributed only by planning boards. When a patient looks at how a single-payer national health plan would operate, in essence, all people would have access to comprehensive care. There would not be costs out of pocket at the time of service. One would be free to choose their own doctor. There would be no insurance hassles. This information is taken from information published in the New England Journal of Medicine. Funding for this plan would flow into a national health plan fund, which would in turn pay hospitals, both operating and capital monies, HMOs, fee-for-service doctors, home care agencies, long-term care. And all of the sources of revenue, Medicare, Medicaid, individual local and government monies would flow into this fund, and there would initially, while people would in fact pay through private insurance and through their employers, there would be a conversion at this level. After the transition years, individuals would pay through new taxes based on a progressive source of financing. That is, the more you earn, the more you pay in taxes to support the health plan fund. It would not be based on an employer-based system. Now, this is information that illustrates how, in fact, we would do this. It's not a smoke and mirrors concept. If we look at information that's taken from the Journal of the American Medical Association and we look at an index year, now we thought we were spending a lot of money in 1991 when we were spending $602 billion. Turns out not as much as we are now. Under the policy, if we take that same index year and look at $602 billion, we would keep hospital care the same. We would expand, so under current policies and national health plan policies, things would be the same. There would be a modest increase in physician services. Other services would stay the same. We would convert insurance overhead and put it into transition and new programs. This is another way to look at that same concept, because we're talking also about achieving tremendous savings to help us expand to all the individuals that aren't covered. So when we look at how we're planning to cover new costs under a national health plan, we're not planning to raise taxes so much. Once again, we're planning to do a conversion from existing costs. Now, if we focus on this, the next slide, which comes from the Grumbach article in the Journal of the American Medical Association, what you can see is that hospital billing savings, which we estimate would be in the area of $31 billion, would go directly into patient care. Savings from doctors' offices in their billing practices, because they won't have to employ someone to help them finagle 1,500 different insurance plans. We would take that money, plus we would add some money from insurance overhead. Then we would take the rest of the money and we would use that for our transition costs. Now, lots of people will ask, well, will this work? Can this work? Has it ever worked before? Have we ever tried it before? Of course we have. We've tried this directly north of us. In the last 30 years, there have been 2 experiments going on in North America. One in Canada, the other in the United States. If you look at the following slide, which comes from the statistical information from both the United States and Canada, you can see that in the early 60s, if the red line is spending in the United States and the yellow line is spending in Canada, when we look at percent of gross national product over time, Canada was outspending us in the 60s. After they enacted their Health Plan Act, the slope, the steepness of the rise of their health care costs continued to increase, but not nearly at the exponential rate that ours has. The Canadian healthcare system is almost identical to ours. Their research and development is very similar to ours. Many American doctors are trained in Canada. The single outstanding difference between these 2 countries is that Canada has a financing mechanism that's different from ours. Another interesting concept about our friends in the North is how they pay for their health plan. Do you remember earlier we looked at a slide that showed how regressive the financing was in the United States, where the poor pay more for their health care? The next slide illustrates how Canadians pay for their health care. And it comes from Canadian health care information. When we look at family income, share of health payments as share of income, you can see a complete reversal of the American system. The poor pay less, the rich pay more. Some people believe that this is fair financing. The more you earn, the more you should pay. I'm going to draw to a close here with some slides that come from Montana. This slide illustrates satisfaction, and we can see that Americans are not very satisfied with their health care system. Canadians are much more satisfied. No one is perfectly satisfied. If you look from top to bottom, we're still in the 60% range, but Canadians are much more happy. And when we look at mandate for change, you can see that satisfaction with the current system of health care has decreased as a real mandate for change is being called for. We know that public opinion on health care reform continues to indicate a few concepts that I think are really important to talk about. And this comes from Opinion Research Corp, which is like a Gallup poll group. And that is that the bulk of Americans favor a national health insurance system where all of us are rolled into the same risk pool. It doesn't matter if we're Democrat or Republican, white or black, low income or high income. Two interesting facts that I think are especially pertinent is that many believe that we should prohibit paying extra for better care and that we should prohibit paying extra to avoid waiting. Very few favor expanding Medicaid to cover all or for the unemployed. When we ask physicians what they think about health policy, we have some kind of a set of curious findings. While we know that the majority of physicians favor health care reform, most of them also think other doctors will not support it. The next slide illustrates something called the hassle factor. Now, this poll was published by Metropolitan Life, which is one of the largest insurers in this country, and physicians were asked would they accept a 10% decrease in their income for less hassle. And if you look, you can see that many of them would accept a decrease for less paperwork. It's not so clear about utilization review or malpractice limits, but the paperwork, paper chase is driving doctors nuts. Health economists have a wide variety of opinions, but you can see if you look at what they think about employer mandate, most of them think it wouldn't work. Many of them favor a Canadian policy over a United States system, although once again it's a close call. Okay, here come our Montana slides. Now when we look at healthcare spending, people say, well, how much are we spending here in Montana? When we look at this slide, you can see some curious facts. And that is that in Montana, in the year 1990, which is the last year, incidentally, that we have really good figures that are not just projections, in the year that we know that in the United States we were spending $602 billion, Montana was spending $1.6 billion. And what's interesting is, in that year, healthcare spending equaled the entire state budget for the state of Montana. Now, when we look at what is estimated for 1994, we're estimating $1 trillion for the United States as a whole. In Montana, we're estimating almost a doubling of healthcare costs in that time period. So the slide to follow illustrates where the dollars go in Montana. And as is true throughout the nation, this is information that comes from the Healthcare Financing Administration and Montana Public Health Partners. The bulk of monies go to hospitals. Some go to physicians and some go to other areas of expenditure. Where the dollars come from in Montana is actually relatively complex. When we look at this slide, you can see that we have roughly a third coming from employers, a little less than that coming from out of pocket, but this whole area is called public spending. When we hear the buzzword, oh, we don't want government to be in health care, it's important to understand that the government is already in health care. This slide breaks out that part of the slide a slightly different way. And when we look at public versus private sponsors of health care, what you can see is this lower area is almost half of our total expenditures. Now that averages public health, Medicare, Medicaid, VA, Champus, but we have roughly 46% of expenditures in Montana currently now come from public sources. When we look at increases in public spending, many people want to know how we're spending that money. Are we spending it on better public health initiatives to promote good health and prevent disease, to immunize children, and to provide prenatal care? When we look at this slide, you can see that no, in fact, we aren't doing anything very innovative in health care. Largely what we're doing is we're underwriting our state, federal, Medicaid, and paying for Medicare. Innovative other public programs comes out with a poor showing relative to where the bulk of our public monies are going. And this is the most inflationary area in healthcare spending in the state today. When we look at business health costs in Montana, we can see that the largest companies in Montana who provide health insurance to their employees roughly pay somewhere between 60 and 80% of their employees' coverage. When we look at percent of payroll, you can see that it's pretty steady at roughly 8%. In the area of schools, public servants, universities, state employees, you can see that that's a whopping 10%. The next slide illustrates a very interesting concept, and that has to do with how we're going to achieve real savings in our system. What we know for the years 1989 through 1991, information that's been provided to us by the National Association of Insurance Commissioners, we weren't able to get current insurers in Montana to help cooperate with us. This slide illustrates what's called a loss ratio. Now, it's kind of a complicated concept, but it's really not that complicated because the loss ratio is how much you collect in premium versus how much you pay out in claims. When we look at the three index years of 89, 90, and 91, you can see that health insurance companies in Montana roughly paid out $90 million less than they collected in each of those years. We think we need that money. We need that money to provide health care for individuals in this state. And that's a way we can take a savings, we can achieve a savings without increasing a further tax burden. I think that it's really important at this point, as we proceed into 1994 and look toward the 1995 legislative session, to know that Senate Bill 285, which was passed by our last legislator, is calling for us to decide as Montana citizens whether we want a multi-payer plan for covering Montana citizens with a good health care package, or we want a single-payer plan. I hope you've had a chance to see the two different concepts, the two different methods of financing, and I hope you will in fact approach your legislator about the one that you think is most likely to be effective. When dealing with legislators this year, you need to remind them that we need a program that covers everyone for all medically indicated services, and one that is fairly financed. Thank you.